Good morning, students. Today's my lecture topic is on chronic periodontitis. I am Dr. Manovijay, Associate Professor from Department of Periodontology, VMSDC. So what do you mean by chronic? Chronic means something it is of longer duration. Peri refers to around. Dont, it refers to teeth. Itis refers to inflammation. So it, as the name indicates, we know that chronic periodontitis refers to inflammation of the supporting tissues of the tooth that is of longer duration. So what does the proper definition mean? It is an infectious disease resulting in inflammation within the supporting tissues of the teeth, progressive attachment loss, and bone loss. Here, infectious is due to the microbial nature. It is because of the subgingival microbiota. Normally, we call them periodontal pathogens, and it refers to the red complex of microorganisms. So, because of the microbial products, it leads to inflammation of the gingiva. And because of the inflammation, it leads to attachment and alveolar bone loss. So, this is the gist about a chronic periodontitis. How we will see the clinical features. As I told you, microbial deposit is the major etiological cause for periodontitis. So here it refers to the plaque and calculus. Can you see the plaque and calculus deposits over the tooth here? They are adherent to the tooth surface. Because of that, you can see inflammation of the gingiva. Can you see the inflammation here? Because of this, there is bleeding of gums. There is swollen gingiva. There is loss of stippling, and it also leads to pathological migration of the teeth. Here you can even see pus discharge here. So all this leads to attachment loss. You can see the receding gums, and it may lead to tooth loss also. These are the clinical features. So let me recap. So chronic periodontitis is something is of longer duration, and the plaque and calculus seem to be the major etiological factors. Because of it, it leads to gingival inflammation, pocket formation, and loss of attachment. How will you diagnose chronic periodontitis? You have to correlate both the clinical and radiological findings. Sometimes clinically, the lesion may appear to have it looks to be firm and fibrous because of its chronicity, and bleeding may not be evident in case of smokers. But if you look radiologically, there will be so much of attachment loss. So you have to correlate the clinical and radiological findings before coming to a conclusion whether it's a periodontitis or gingivitis. One distinguishing feature between gingivitis and periodontitis: gingivitis, it will not lead to loss of attachment. That is, it will not lead to pocket formation, furcation involvement, recession, or mobility. Whereas periodontitis may be associated with any of the above symptoms. That is, it may be associated with pocket formation, furcation, mobility, or recession. This is the main distinguishing features between the gingivitis and periodontitis. Gingivitis is limited only with gingiva, whereas periodontitis is related to the supporting tissues of the tooth. Based on the disease distribution, chronic periodontitis has been classified into localized chronic periodontitis and generalized chronic periodontitis. It is a site-specific disease. What do you mean by site-specific disease? For example, if there is food impaction in the mesial aspect of first molars, lower first molars, there the attachment loss or the pocket formation will be around 6 mm. Whereas in the distal aspect, it looks to be healthy, where there is a shallow pocket or it is healthy without 2 to 3 mm of gingival sulcus, then there will not be any periodontitis in that region. So it is very site specific. Okay, and based on the percentage of involvement in the oral cavity, it is classified into localized and generalized. If less than 30% of attachment and bone loss occurs in the mouth, then it is called as localized chronic periodontitis. You have to write it as localized chronic periodontitis when you are writing in your case sheet. It should not be written as localized periodontitis, because we have got aggressive periodontitis too. So you have to be specific in your answer when you are writing in your case sheet. And another thing is generalized chronic periodontitis when there is greater than 30% of attachment and bone loss. So again, I repeat, based on the disease distribution, chronic periodontitis is classified into localized chronic periodontitis and generalized chronic periodontitis. If it is less than 30% of attachment and bone loss, it is localized chronic periodontitis. If more than 30% of attachment and bone loss occurs, it is generalized chronic periodontitis. I will ask you a question now. Let me say a male patient of name Karthik come to your dental OP and you are the dentist there, and then age of the patient is around 30 years of age and he is having 32 teeth in his oral cavity. Of the 32 teeth, 6 teeth are found to have 6 mm of probing pocket depth. Here PPD refers to probing pocket depth. Now you say me whether it's having localized or generalized chronic periodontitis. I'll give you 2 minutes time. You can write in a paper. Again, I repeat, a patient is having 32 teeth in his oral cavity, of which 6 teeth were found to have 6 mm of probing pocket depth. I told you only 2 to 3 mm is considered to be normal gingival sulcus depth. If it crosses more than 3, then it is periodontitis. So what does it mean? 6 mm of probing pocket depth means he has got 6 teeth affected with periodontitis. Out of the 32 teeth, 6 teeth are being affected with probing pocket depth. Now you classify if he's having localized or generalized chronic periodontitis. Okay. Now I'll give you the answer how to calculate. This may be the oral findings of the patient. Here you can see the lower anterior being having periodontal inflammation. There is bone loss too. Okay. I told you out of 32, 6 teeth are being involved. So 6 out of 32 into 100 gives you the percentage. That is only 19% of the whole mouth is being infected or having clinical attachment loss. So now you say me whether it's localized or generalized. It is localized chronic periodontitis because only less than 30% of the teeth is being involved. If in case patient is having only 8 teeth, out of which only 6 are being involved, then it will go to generalized chronic periodontitis. So always put the calculation and then you diagnose it. It is very, very important when you're writing in your case sheet. All these things you have to think in your mind when you're recording a case sheet in your final year practical session. And chronic periodontitis may have 2 types of bone loss. One is horizontal or vertical bone loss. When the rate of bone loss occurs at a uniform rate, then you have horizontal bone loss. In angular bone loss, one side may be having more attachment loss than the other. That will lead to angular or vertical bone loss. So in horizontal bone loss is normally associated with supra-bony pocket formation, whereas vertical bone loss is associated with infra-bony or intra-bony pocket formation. Based on the disease severity, I told you how you classify it into localized and chronic. Now, based on disease severity, you can classify it into slight, moderate, and severe. This is based on clinical attachment loss. That is when you measure from the CJ to the base of the pocket. Here you can see the healthy gingiva, and it is mild periodontitis, moderate, and severe. Can you see the rate of attachment of bone loss here? Can you see the round circle there? So in slight periodontitis, the rate of attachment loss will be only 1 to 2 mm, or the periodontal dissection is only 1 to 2 mm of clinical attachment loss. In moderate, 3 to 4 mm of clinical attachment loss will be there, and in severe, when more than 5 mm or more of clinical attachment loss has occurred, then you call it a severe periodontitis. Do not confuse with clinical attachment level and probing pocket depth. Probing pocket depth is something related with soft tooth changes. That is, you measure from the gingival margin. Here, if the gingival margin is here, you will be measuring from the gingival margin to the base of the pocket. If for clinical attachment level, you will be measuring from CJ to base of the pocket. When the CJ and gingival margin are the same level, then CAL is equal to probing pocket depth. So based on that, I'll show you a video how to measure the probing pocket depth, or how you will categorize into mild, moderate, and severe. This is what I told you. Here you have got mild, moderate, and severe. You can see the, can you see here? It's only 1 to 2 mm, the periodontal pocket, 3 to 4, and then greater than 5 mm of clinical attachment levels from here, from CJ to the base of the pocket. Here is a video graph that shows the healthy gingiva and how it develops into periodontitis. Okay. So this is the Williams periodontal probe. You have markings 1, 2, 3, 4 and 6 will be happen, 5 until 10 markings will be there, and it is used to measure the periodontal pocket. Can you see here? It is a healthy gingiva. It is a healthy gingiva, and the normal sulcus depth is only 2 to 3 mm. What is the normal sulcus depth? It is 2 to 3 mm. And because of biofilm, can you see the biofilm? It's forming here. There is gingival inflammation and loss of connective tissue fibers occurs. There is a pathological deepening of sulcus. Now it is 4 to 5 mm of pocket. So it is becoming moderate. periodontitis. From mild periodontitis it is becoming moderate periodontitis, and you can see the pathological deepening of the gingival sulcus, and can you see the supragingival as well as subgingival plaque and calculus. Now the probing depth is around 78 mm. Here the furcation area, you can see the loss of connective tissue fibers here on all the areas because of the biofilm, because of the noxious products that are secreted from the biofilm. Now again there is attachment loss. Now you can see it is being invading the furcation area. Can you see the furcation area? Now it's invading the furcation area, and there is alveolar bone loss too. Can you see here the inflammation? The red color shows the inflammation. It is invading there, and there is connective tissue loss and attachment loss also. So further, what it will lead to? It will lead, because of the loss and support of the alveolar bone, it will lead to mobility. You can see mobile teeth here, and further the loss of tooth occurs. This is what happens in periodontal tissue. That is, gradually it progresses, leading to tooth loss. So on time management of chronic periodontitis is very, very important. So what are the symptoms? So symptoms means what the patient says to you. Signs is what you elicit from the patient. That's what I showed you in clinical features. Symptoms, they guide you to give a better diagnosis and treatment. So the patient may have halitosis, bleeding gums. So let us see one in detail. The first thing the patient notices during periodontal disease is bleeding of gums while brushing. The brush will have gingival bleeding. This is where you start noting that you are having a gingival problem. So bleeding of gums is one of the major indications for periodontal disease. Then you can see discharge. There is a change in the consistency of the gingiva. There is swollen gums. And the patient may say that he is sensitive to both hot and cold drinks. And he may also, because why the sensitivity is there? It may be due to the periodontal disease or apical migration of gingiva. Recession is there. The patient will say, my gums have started to recede. Also, they'll say pathological migration. They say my teeth has started to move from each other. It has started to migrate. It was normal before, but after some days, I noticed bleeding of gums. Then my teeth has started to move apart or drift apart. So this is one of the common features of periodontal disease. And an interesting fact that you always ask patients is that they all say they have itchiness of the gums. Why it happens? It is because of food impaction. Because of food impaction, the patient will have dull gnawing type of pain. He knows, he always starts to live with the pain. He accepts the pain and starts to live with the pain because it's only dull gnawing type of pain, and he says that the pain gets relieved while he is using a toothpick. Can you see the patient is using toothpick? So these things, when the patient is coming to the clinical setup, you should ask the patient whether he is having itching type of pain or sharp pricking type of pain. If it is sharp pricking type of pain, you should think about periapical abscess or any acute disorders. But chronic lesions, that especially chronic periodontitis, they will say dull gnawing type of pain that gets relieved while using a toothpick. Finally, the patient may say that my tooth has started to become loosened or it has become mobile. So all these symptoms you have to record to diagnose chronic periodontitis. So to put it in a nutshell, the patient will complain of bleeding on brushing, bleeding of gums while brushing, hypersensitivity, then the recession, pathological migration, bleeding of gums, halitosis, and finally mobile teeth. So now we are classifying periodontitis based on the disease severity. Again, based on the disease progression, chronic periodontitis has been categorized into 3 models. That is continuous model, random model, and asynchronous model. That is based on the disease progression, it is classified into continuous model, random model, or asynchronous or multiple burst model. In the continuous model, the rate of destruction will be consistent. It will be slow and steady. There will be uniformity will be there. If there is 1 mm of bone loss per year, it will be the same for the next year also. It is a continuous model. In random model, what we see is there will be disease activity at particular stage, then there will be a pause, that is inactive stage, then again there will be active stage. For example, if it is in the upper molar, there is periodontal disease activity which is seen as bleeding gums or pus discharge or any other features of periodontitis, after 2 or 3 months it will be normal, or for 1 year it will be okay. Then again it will start in another site, maybe in the lower molar. If it has started in upper molar, and it will start in the lower molar, and it will be random model. It is not, it will be particular to that tooth alone. It will be random model or episodic burst model. So in certain periods of inactivity followed by certain periods of remission will be there in random model. In asynchronous model, in the same tooth but at different sites, the disease activity will be more. For example, in the mesial site, if it is disease activity is high at one period, then after some time the disease activity will be higher in distal surface, and it will occur in different sides of the oral cavity, and it will occur in multiple bursts. So this is known as multiple burst model. So we have got continuous model, random model, and asynchronous or multiple burst model. And for any disease, there will be some risk factors or prediction. We can predict that if the patient is having this social problem or behavioral problem, he is more prone for chronic periodontitis. So what are these? Prior history of periodontal disease. If the patient has got all the symptoms of periodontal disease like gingival inflammation, pus fissure, and he has not undergone any treatment, then he is more prone for periodontal disease than a patient who has undergone periodontal therapy. So this is one of the predictors for chronic periodontitis. Second one, if he's having biofilm, continuous biofilm, that is, and that biofilm formation is favored by anatomical abnormalities. Maybe it is more in furcation normal. If there is any incomplete restoration, these areas can act as a niche for the local factors, especially plaque and calculus. I told you red complex microorganisms are more involved in chronic periodontitis, and they pose a risk for the chronic periodontitis. Third one is systemic factors. It is a two-way relationship. What do you mean by two-way relationship? Periodontitis can affect systemic problems. Similarly, the systemic changes that affects the human body can aggravate periodontitis. So they can pose as a risk factor for periodontitis. Some of them are diabetes, cardiovascular disease, Alzheimer's disease, rheumatic disease, respiratory disease. Because pro-inflammatory cytokines are produced in both, and they will aggravate the conditions. That is, periodontitis can influence systemic disease, or systemic factors can have influence on periodontal disease. In that, I'll be elaborating on diabetes. What happens in diabetes is there is production of advanced glycated end products. This advanced AGE means advanced glycated end products. These advanced glycated end products, what they will do is they will act on endothelial cells, fibroblasts, and macrophages. You all know endothelial cells form the lining of the capillaries. So if the increased production affect the endothelial cells, or when they get joined with the endothelial cells, they causes increased permeability of the blood vessels, leading to increased susceptibility of infection. So once there is a gap, there is an increased susceptibility of infection, and it will also impair healing. That is natural. Similarly, if it affects what are fibroblasts known for? They are known for collagen production. If they affect the fibroblast, there is a decrease in collagen production. That also lead to increased susceptibility to infection and impaired healing. And last but not the least, it affects the macrophages. So the macrophages will have RAGE receptors. These AGE receptors will join with the RAGE receptors in macrophages. What is RAGE? Receptor for advanced glycated end products. So AGE is advanced glycated end products, and these bind with the receptors on the surface of the macrophages. That will make them to be hyperactive macrophages. What these macrophages do is that they become hyperactive, and they produce the increased production of pro-inflammatory cytokines like TNF-alpha and interleukin-1 beta. These pro-inflammatory cytokines can destroy connective tissue. All this leads to periodontitis. So again, I repeat, diabetes results in the production of AGEs which affects endothelial cells, fibroblasts, and macrophages. That will lead to increased permeability and molecular adhesion, decreased collagen production, hyperactive monocytes, that leads to formation of TNF-alpha and interleukin-1 beta, that leads to periodontitis. This is how diabetes affects the periodontitis, or it is a two-way relationship. So how periodontitis affects diabetes is that it increases the hyperglycemic level. That will be dealt in periodontal medicine chapter. That is separate chapter for that. And next one is the smoking and periodontal disease. Smoking, which will affect the microbiology. Even in shallow pockets, will have deep we'll have subgingival microbiota that is found in the deeper periodontal pockets in case of smokers. So what I mean is, the pocket may be around only 5 mm, but the microorganisms found there will be of very pathogenic, and it will also affect the immunological responses. It will increase clinical attachment loss, and it will decrease the periodontal treatment outcome. So smoking is very deleterious to the oral cavity and the periodontium. But bleeding will be less in smokers. That doesn't mean clinical attachment losses level. That is more. It leads to deep periodontal pocket, but bleeding will be masked, or it will not be shown as it is severe in gingivitis or other periodontitis condition. Next one is stress. We'll see how these conditions affect the periodontitis. Because of psychosocial stress, there is a behavior change. What does that behavior change means? He may become a chronic smoker, or he may become an overeating candidate. So also, he may not have good compliance with oral hygiene. That is, his maintenance of oral hygiene will be poor. That leads to bacterial infection leading to periodontal disease. Or overeating lead to increased production of cortisol, the hormone, which leads to depressed immunity, leading to bacterial infection, and that leads to periodontal disease. So the behavioral changes may be associated with smoking or overeating or poor compliance with the oral hygiene, or leading to periodontitis. And stress and smoking are also like associated with each other in causing periodontal disease. Genetic factors. What they are shown is, if a patient is having genetically susceptible to periodontitis, then he can have periodontitis at 2.51 rate higher than a normal individual who is not more susceptible to genetic, or who is not genetically susceptible to periodontitis. And if he is a smoker, then the rate of affecting the periodontal condition is around 7.1 times. So genetic makers may play an important role, especially in causing a disease. You may think some people have less amount of plaque and calculus, but they'll have more deeper pockets. But some people have more amount of calculus and plaque, but they'll have only shallow pockets. All these are because of the genetic makeup of the individual. So this is the final video I like to show you. It is the complete nutshell of the chronic periodontitis, what I have taught you so far.
Periodontal disease begins in the gingival sulcus, a cup of soft tissue around the necks of the teeth.
Please listen carefully.
Through the gums. Healthy gingiva are pink in color, and the sulcus depth ranges from 0 to 3 millimeters, measured from the tip of the gingival margin to the base of the sulcus. The attachment fibers connecting the gums to the teeth and the teeth to the bone are intact. The gums are resilient and neither bleed nor hurt when being probed. During meals, food debris accumulates in the sulcus. When mixed with mouth bacteria and proteins from saliva, plaque and less obvious biofilm are formed. Both are harmful to teeth and periodontal structures. Left in place on the teeth, bacterial plaque and biofilm begin to mineralize, forming hard deposits called calculus, which can only be removed with dental instruments. In response to the increased bacteria adjacent to the soft gingiva, the body sends immune cells and healing cells to the area by way of the circulation. Increased blood flow to the gingiva produces red, enlarged, and tender gum tissues, a reversible condition known as gingivitis, in which the periodontal attachment fibers remain intact. Continuous exposure to acids and enzymes from plaque bacteria and the body's immune response to them eventually causes the periodontal attachment to be lost, an irreversible condition known as periodontitis. The sulcus depth increases to the point where the patient can no longer effectively remove plaque, leading to the destruction of tooth supporting bone. Smoking impairs blood flow and can significantly interfere with a patient's ability to fight the bacterial infection. Other factors may be involved. Generalized periodontitis affects all of the teeth. They may loosen, appear unnaturally long and unattractive, and may ultimately be lost. When multiple back teeth are lost,
you can see the TMJ problem here because of the pathological migration.
They begin to tip and move. The cheeks begin to collapse inward where the back teeth are missing, and the lack of proper support for the jaw joints may cause them to ache, pop, and click. Periodontal bacteria can enter the body's circulatory system through leaky blood vessels.
This is what I told is two-way relationship.
Lead to blood
how the bacteria in the periodontal tissue leads to the systemic conditions.
Heart disease, heart attacks.
They are carried to the systemic circulation. So that's all about periodontitis, and this is one of the recent concepts. So I told you bacterial plaque is the main cause for periodontitis, but nowadays there's a virus also play an important role. How does virus affect is that in a healthy gingiva, because of bacterial plaque, there is gingivitis that we all know. Because of gingivitis, there is influx of inflammatory cells. These inflammatory cells may contain latent herpes viruses. What do you mean by latent herpes? In case if I had herpes infection at my younger age, these viruses will be latent in my inflammatory cells. Okay. And these cells are activated by the immunosuppression or infection, stress or hormones. When these viruses are activity, they will show periodontopathic property. What does it mean? They release cytokines, they cause immunosuppression, they also cause direct cytotoxicity, which will further lead to overgrowth of pathogenic bacteria, further causing destructive periodontal disease. So this is recent concept, that is viruses in periodontal disease. You can just note down the flow chart, and if you write this flow chart, you will be awarded 2.5 marks out of 5. If you are writing the pathogenesis, this flow chart is very, very important. Okay, this is the recent concept in the etiology of periodontal disease. So to conclude, what is the goal of any treatment? The goal of any treatment is to restore health. So here in chronic periodontitis, our ultimate goal is to promote or to restore the periodontal health. For that, you have to start from the etiotrophic phase, that you have to start with a non-surgical therapy, non-surgical periodontal treatment. That is, you have to remove the plaque and calculus by scaling and root planing. You can also go for local drug delivery if in the pocket depth is less than 5 mm. In case if you are not able to access the periodontal pocket, then you go for periodontal flap surgery. Based on the regenerative and resective properties, you can go for regenerative or resective osseous surgery. It all depends upon the bone architecture. So the ultimate goal of any periodontal treatment is to restore periodontal health. That should be your ideology for treating the chronic periodontitis patient. And most important is you have to call for maintenance. Only when you call the patient for supportive periodontal treatment, the treatment will be fulfilled. Thank you so much. These are my references. And students, if you have any questions, you can mail me to my email ID, that is drmanojay@vmst.edu.in. I'll be there to help you. Whenever you have just queries, just message me. I will give you my answers. Thank you so much.